Having concluded the three talks that we had scheduled for this evening, we're now moving on to the final session of the Q&A. I suppose I'll open up the forum at this stage. We'll probably start with people who are physically here and then probably look at the online questions that Louise is kindly monitoring for me. Any questions from the audience here? I'll kick off one question starting with Rochelle and then come to Will as well. But Rochelle, the microdialysis, and I've done some work on microdialysis, but microdialysis is an invasive technique or semi-invasive technique, and it's probably not able to be done at clinical sites around the world, actually. So people would be looking at using this information to guide antimicrobial prophylaxis for surgical site infections. Do you have any plasma concentration correlates to the microdialysis concentration? Because we would probably have more sites actually be able to measure plasma concentration of cefazolin and antibiotics as compared to microdialysis. And if you have a correlation, then perhaps one could actually measure a plasma concentration and be able to extrapolate what the tissue concentrations would be?
Yes. Thanks for that question, Jayesh. Yes, microdialysis is quite a specialist technique and not available to everyone. I think the correlation between the unbound plasma and the interstitial fluid concentrations in our study, I have it written down, it was variable and it was around the 30%, but that was reduced. Sorry, message. But they did also show in that Brill study I talked about that the penetration in the non-obese patients was about 1-to-1, but I think it was around 0.7 in the obese patients. So it does highlight the need to probably be measuring it if possible at those target sites if available.
That's excellent. Just as a follow-through question, there's a growing body of literature that is moving across from BMI to body composition. What's your take on that actually in respect of the work that you're doing?
Yes, definitely. That's an interesting question. And when we were doing the pharmacokinetic modeling, we did look at what body size index best correlated to the model. And sorry, Jayesh, I don't have it at the top of my head at the moment. If it was body weight or BMI that best correlated to that volume of distribution.
Yeah, it'll be certainly an interesting thing going forward, actually, I suppose, as an area of interest. I'm sure you'll pursue that actually going forward as well. Rochelle, you got an online question from Michelle Cree. Having gained this information that you've done with your fantastic work, what changes have you made in terms of your clinical practice?
I'm definitely more particular about the timing of dose. And I think, our last speaker sort of alluded to what actually happens in clinical practice. And I think often we give antibodies at the timing of induction, which can be quite close to skin incision. So now I'm quite particular that I try and give it pre-induction, which has other advantages as far as detection of allergy as well. So timing is important, but also the dose. And I actually I still stay with the guidelines that if the patients are over 120 kilos, then I still give 3 grams. That probably is not in line with our study, but I think the harm of getting an extra gram of cefazolin in my patient population that I treat is really low.
Fantastic. Look, there's one more question for you. It actually has got 2 parts, so I'll just go with one part at a time. You spoke about cefazolin dosing for adult surgical prophylaxis. The question is around MRSA colonized patients. Do you prefer to use vancomycin or teicoplanin for surgical antimicrobial prophylaxis in these patients?
Mm-hmm. I use teicoplanin. I think the guidelines are moving towards that, but definitely the infusion time needed for vancomycin often means that it's hard to get in with enough time before surgical incision. So for that reason, I've moved towards teicoplanin, as I think the guidelines are kind of suggesting as well.
There's a follow-up question to that. So if it is teicoplanin that you're going to use, then are you at all concerned with the data presented by the NAP6 results around teicoplanin's rate of allergy?
I think it definitely is a concern. And I was actually at a conference at the weekend with one of the anaesthetic allergy specialists there, and they made the comment that we're not seeing the teicoplanin rates of anaphylaxis here in Australia, but he suggested that's probably, we just haven't had the exposure to it yet. And as we continue to use teicoplanin, I think we do need to keep an eye on what our rates of anaphylaxis are, because that definitely is a concern, as was brought out in the NAP6 data in the UK, where they've been using it for longer.
Fantastic again. All right, and then we'll go out to Will. We've got an online question for you, Will. With prosthetic joint infection, they can be acute or chronic. I would think that acute infections are directly from the surgical site, but how do infections develop from a chronic point of view?
Infections can either be basically begin as a surgical site infection, and they can either be a contaminant that has laid dormant for a long time, or there can be a hematogenous process as well, where bacteria can be deposited in a joint and use that as a sort of nidus to grow from there. The exact definition is still up for debate in orthopedics, really, especially the acute infections that appear. Some can be late acute, whether that's a chronic infection that's already established a biofilm, or whether that's a true acute infection that's only started in the last few days, is certainly a point of contention, and mostly affects the treatment protocol that's used surgically between a debridement only compared to a major revision.
Thanks, Will. So from my end, there's one question. I was a bit disappointed that you didn't speak about bacteriophage. Actually, it is my area of interest. I'm sure there is a lot to speak in that sort of zone. You obviously covered a lot in terms of delivery of antimicrobials, including the hydrogel, which seems to be the way to go forward. What about non-antimicrobial ways of prophylaxing? There's a lot of work being done in that area with regard to using sonication techniques and other things to disrupt the biofilm. Do you have a particular view on that?
Yeah, my view is that there are a lot of techniques, basically, a lot of things that are being suggested, a lot of things that are at the preclinical stage, electrification of implants as well, sonication. Everything is not, the evidence isn't there at this stage. They're all good ideas, and some have some very promising in vitro results, but nothing has really transitioned and made the jump to the clinical area at the moment.
Yeah, fantastic. Thanks, Will. And then for Nicolette, I've got one question. Look, it's a fantastic body of work you've done, actually, with all the bundles and other things. If it is exactly as you demonstrated in your last slide, that it's actually come to a stage where it's matching the, I suppose, world standards, actually, the surgical site infection rate, to be ambitious and actually be able to even drop further, what else do you think we could consider actually adding in the bundle, actually, to reduce the surgical site infection further?
Thanks, Josh. And hi, everyone. That's a great question. So one thing I've learned through this process is that surgical craft groups are all very competitive. So we're aiming for zero, and that will benefit our patients hugely. But I think there's a lot of work that we can do in the surgical antibiotic prophylaxis space. Certainly from our drug exposure and our drug delivery, one of the things that we have been starting to look at is the use of loading doses and continuous infusions for the length of surgery, because in each of our audit periods, we've demonstrated we're not very good at doing repeat dosing. Certainly, we are seeing a bit more obesity in children. So we do need to cater for them in our guidelines better, as Rochelle's demonstrated, and making sure we use the right doses and optimize dose exposure. I think in the antibiotic allergy space, I'm very excited that we are looking at engaging with our pre-admission clinic to identify those patients with penicillin allergy labels early and actually, if they are low risk, so delayed non-severe type reactions, which in children for the most part, about 95% of them with a penicillin allergy have a viral exanthem, not a true allergy, is actually being able to challenge them to a penicillin pre-op, not before they come in, but a week or two out, and actually delabeling them. And that way they can receive their beta-lactam as their first-line surgical prophylaxis choice, which we know is so much better and does reduce your risk of surgical site infections. And then in terms of MRO colonisation, we've done quite a bit of work in that space through our infection control team. In terms of delabeling patients, interestingly, there is historically a trend to really keep an MRO label for a very long period of time, and that's not always clinically appropriate. Sometimes it is, but not always. And so there's a lot of work being done to ensure that patients who are not considered MRO colonised anymore are actually delabeled so that they don't need to get that vancomycin infusion. And as Rochelle pointed out, the difficulty with delivering that so that the dose is in before knife to skin time. As far as knife to skin time goes, that's a really interesting concept. Mel, our surgical nurse, who's actually a scrub nurse herself, a clinical nurse, has often spoken about what happens within the theatre space. And it's engaging every member of the team to be able to speak up and actually making that someone's responsibility to say, hey, actually, it's now knife to skin, is the drug in? And so, it's just optimizing speaking up for patient safety within the theatre space as one way of intervening and improving patient care.
Sounds like you've got a very good plan going forward. Actually, I was very happy to hear about the continuous infusion aspect, I suppose, because our very own Professor Lipman actually finished that BLINK study demonstrating significant survival benefit actually following beta-lactam infusion as compared to intermittent dosing. Just speaks volumes in the area that possible application in this area as well. So wonderful work, and obviously wish you all the best with implementing all those interventions. I'm sure that will result in significant improvement in patient outcomes as well. Oh, look, we've got Will wanting to ask a question to
Nicolette.
Nicolette. Okay.
That's all right.
Yep.
I'm just wondering, Nicolette, about the introduction of the triclosan sutures in your hospital. How did you do that? Was that a single point in time, or was that based on a particular area or specialty? I know from experience in the hospital I'm currently working at, on a Friday afternoon, they removed all of the non-triclosan coated sutures, and then on the Monday, they were all that were available were changed to the triclosan coated versions. I think that went over most people's head because they just used whatever they were given, but I think it was a significant change. So I'm wondering how you've introduced that and which particular areas it's had an impact in.
It's a great question. And certainly the method you've described is one way of going about it. I believe Bhavesh and Mel and the team actually met with the different surgical craft group directors and introduced it as a potential intervention as part of the surgical bundle, and asked for an opt-in, so who wanted to be part of the pilot. And I have to say, I think 80% of them put up their hands and said, we're interested, but we still want access to our preferred sutures. And so Bhavesh, I believe, responded by saying, okay, the trial period will be X amount of time, and at which point we will do a review, look at our surgical site infection rates and receive feedback and look at adverse events. And then if everyone's in agreement and this is the threshold we're happy with, then we switch over completely. And so there was an in-principle agreement between the surgical directors that if they achieve that outcome, that they will switch over, and they did. So it was a negotiation, but I thought very well done on Bhavesh's part in particular, just the way he's come alongside his colleagues and worked with them to bring them along on the journey. I think when we talk about that marginal gains principle, that in-person colleague to colleague influencing is really valuable. So yeah, that's how we went about it.
Thank you. Yeah, that's excellent.
That's a very collaborative model of implementing a change, actually, I would like to say. So well done to your team, Nicolette.
Thank you. Yeah, kudos to Mel and Bhavesh. They've done excellent work.
Yeah, no, please pass on our congratulations to them as well. Oh, yep. I've got another question too.
I have worked quite a lot in prosthetic joint infections as well in Spain, and we normally use the spacers with cement. I'm very curious about the hydrogel. We never use it. Could you explain, like, when do you use it? Like, it's you put it in every new prosthetic joint.
Do you mean the DAC?
Like your hydrogel.
Yeah. So it's a whole group. It's basically a class similar to bone cement or the calcium-based carriers. The one that's available to us clinically in Australia is the DAC, which is the prophylactic. That currently you put it on any joint replacement as you're putting it in. It's not. It doesn't have any antibiotics in it. You mix the antibiotics in that you want to mix in.
The ones that you want.
Yep.
Depending on the colorization of the tape.
Yep. Or in a prophylactic setting, if you want to mix in cefazolin, vancomycin, gentamicin.
So the gel is just a carrier and you just put in whatever you like, actually.
Is it automatic that you put whatever you want?
At the moment, there's nothing to say you can't put whatever you want in there. But it's, if that hydrogel is only there for 72 hours because its only intent is to change the implant surface, impair bacterial adhesion, allow the early osseointegration to start, and the body to sort of, or the immune cells to colonize the implant, in one model of thinking about it to prevent the bacteria.
Yeah, okay. And the last question, because the big problem with chronic prosthetic joint infections is coagulase negative stuff. But we still use cefazolin as prophylaxis, and most of them are resistant. So if you want to prevent it, what would you think of putting? Because maybe we should put vancomycin there.
And in my experience, a lot of people are. And then post-op prophylaxis until cultures are back is always guided by infectious diseases in the places that I've worked. I know here the protocol is often vancomycin and cefepime, which I think is relatively common. But a lot of the time, because of that same issue of you can't change the antibiotics once the culture results are back, you put in something broad spectrum, target the empiric common orthopedic pathogens, and vancomycin often gets the nod.
100%. Fabulous. Any other questions from the audience or online? Excellent. We've had a diverse group of presenters today covering a vast amount of different areas of surgical site infection management, prophylaxis, and so on and so forth. Couldn't have had a better combination of an anesthetist, a surgeon, and a pharmacist together. Very rare to find in clinical areas as well, but there you go. This is one forum that enables that. Lots of synergy. Thank you very much for attending both in person as well as online, everyone. And if there are no further questions, I'll close this session. Thank you again.